quickly rush on to our cases first, then we'll go on to the talks and the topics. So the first case is by Dr. Priyanka. She is a second year general surgery resident. She will be talking on an arterial case. May I request Pareshma sir to be the moderator for the same case?
I am presenting a case of peripheral arterial obstructive disease. My patient is a 68-year-old male, farmer by occupation, resident of Sholapur, smoker. He presented with chief complaints of rest pain of right lower limb and black discoloration of right great and second toe of 2 weeks duration. This is the picture of the patient's foot when he had presented to us. Patient was apparently asymptomatic about 4 years back when he insidiously developed pain in the right calf, which was brought on by walking and subsided after taking rest, and it worsened over a period of 4 years. His claudication distance initially was 400 meters and now it has progressed to rest pain of right lower limb. He also presented with recent onset black discoloration of his right great and second toe, which was spontaneous, progressive, and it was associated with severe pain. His rest pain was localized to right leg. It was burning type, aggravated on limb elevation with partial relief on hanging limb by his bedside. There was also discoloration of surrounding skin with pins and needles sensation, and there was also foul smelling purulent discharge. He did not give any history of trauma, bowel bladder disturbances. There were no risk factors for deep vein thrombosis. There was no fever, postprandial pain abdomen, transient vision loss or limb weakness or impotence. He is a known case of CAD on medical management, hypertensive, type 2 diabetes since last 10 years and chronic kidney disease. He also underwent amputation about 5 years back of his right fifth toe, with diabetic foot. His familial history was non-contributory. Personal history was a smoker since 30 years, consumed around 10 cigarettes per day, and his pack years amounted to 15. Occasional alcohol consumer, and his sleep was disturbed due to rest pain. On examination, he had an endomorph build, conscious, cooperative, oriented to time, place and person. Pallor was there was no pedal edema or generalized lymphadenopathy. There was no tender xanthomas or xanthelasma. His pulse was 100 beats per minute, 3 plus. In right radial artery, normal rate, rhythm, volume. There was no radio-radial or radiofemoral delay. The condition of vessel wall was rigid. His BP was 160 by 90 in his right arm and he was infebrile. Local inspection of both lower limbs on inspection. After taking due consent, patient was exposed from nipples to the level of foot and he was examined in daylight. Chronic ischemic signs in the form of skin thinning, loss of hair, loss of subcutaneous fat, muscle wasting, brittle nails were present in both lower limbs, and his right lower limb showed black discoloration of great and second toe, which was extending from base of toes to tip. It was associated with foul smelling discharge. There was line of demarcation at the base of toes, and there was congestion of sole from tip of toes to mid-foot. His capillary filling time was more than 20 seconds. Venous refilling was more than 5 seconds. He was post-amputation status right fifth toe. There was hallux valgus of great toe and flowing of fourth toe. His skin was dry and cracked. This is the picture. I am showing it again so that I can just reiterate before going to palpation. On palpation, the gangrenous area was tender, his limb was poikilothermic, there was no crepitus. Capillary refill time was more than 5 seconds and venous filling was delayed. His Fuchsic test was negative, there was loss of proprioception and fine touch in right lower limb. Ankle dorsiflexion and plantar flexion was full and free and his power was 5 by 5. His examination of pulses on right side had revealed absent common femoral, popliteal and distal arteries. AVI was not recordable. However, on left side, we could palpate ATA. PTA was not palpable, but on pencil Doppler, his pressure was recorded at 70. So his AVI on left lower limb was 0.87. His systemic examination was essentially normal. So I arrived at a diagnosis of peripheral arterial obstructive disease of bilateral lower limb with critical limb ischemia of right lower limb, Rutherford 6, likely due to atherosclerosis, with level of occlusion at iliac.
So there's one thing which in your examination you could have also helped you to know this is a ischemic level. Can you tell me what you missed? Right at the beginning, after inspection. This is inspection. After
Yes.
that. Next. You straight went to the gangrenous area which is tender.
Sir,
What about temperature?
I have written sir, there was 4 kilotherms.
So how does that help you? Does that give you some idea?
Sir, if the arterial flow is reduced, then the temperature compared to the fellow limb is cold. So that should immediately raise a red flag.
And what is also important is there is sepsis. You expect temperature to go up.
Sir,
So therefore using, and not only that, is feeding the temperature from distal to proximal
sir.
is useful because that gives you an idea of what level of circulation is.
Yes.
What will you do next?
Sir, I would like to evaluate the patient. I would first like to get the baseline investigations and I would like to get investigations to confirm my diagnosis. Baseline investigation, I would want the TLC, the hemoglobin levels. What is more important is urea and creatinine. And
Why?
sir, if I want to intervene in this patient, I want to get a CT angiogram, I would like to know before I give contrast that the patient's kidney status is.
So you have somebody with a diabetic, somebody who's got history of CKD.
So,
All these are likely to be sclerotic vessels.
so.
So suppose creatinine is normal or creatinine is not normal. If it's normal, would you still opt for a CT angio or you would like to do something else?
Sir, before going for a CT angiography, I would like to hydrate the patient before the procedure and start him on N-acetylcysteine, sir. And I would also ask my nephrologist to take a look at the patient and then I would go ahead with the CT angiogram, sir.
Is there any other option besides CT angiogram that you could?
There are options of MR angiography and CO2 angiography, sir.
So when will you opt for MR angio and when you will opt for a CT?
When patient's kidney status is borderline, sir, or the patient is CKD5, not on hemodialysis yet, maybe oliguric, I would prefer going for an MR angiography, sir.
So what's the downside of MR angio?
One is that it takes a lot more time than CT angiography, sir, and the calcification of the vessels is not as clear as in CT.
No, in fact it's the other way around. If they are calcified arteries,
So,
they will interfere with your CT angio. Whereas with an MR angio, you will get better information. And in MR angio, there are two types. One is with contrast and second is without contrast.
so,
So if you have somebody with CKD, you will still do an MR angio without contrast.
so.
Or you always have your Doppler. So next, go ahead. What else did you do after that?
After I had my baseline investigations, I would first want to subject the patient to a color Doppler flow imaging, sir.
So you do CT angio first
No.
and then? Okay.
No, I would definitely get a CDFI, sir, and then depending on the outcome, I would take a call as to do a CT angiography or not.
In bloods, anything else you would like to do?
Sorry, sir.
In the bloods, you said CBC and anything else you would like to do?
I'd like to get an FBS, PPBS, and lipid profile, sir.
What else? You have somebody who's got sepsis, somebody who's got this, so what are the things you would like to do? Because in diabetics, you may get normal WBC count.
So,
So what else would you like to do? Blood test. Blood test. What blood test would you want? Which would be very useful for you?
procal,
Procalcitonin and CRP.
yes.
Yeah. Go ahead. You have anything else to show us after this? Any angles?
Sir, I have a pictorial representation of what the CT angio of the patient was.
Before you show your CT,
Sir.
can I ask you a few questions?
Yes, sir.
Which year of MS are you in right now?
I'm a second year trainee, sir.
I'll ask you some basic questions which are asked in the exams.
Sir.
One, how you said patient has claudication. So how do you define a claudication? What is claudication?
So claudication, claudio means I limp, sir.
To label a pain as claudication, what are the criteria that need to be fulfilled?
Sir, it is a cramping type of pain which is in a group of muscles, reproducible, brought on by exercise and relieved with rest, sir.
The fourth one is not present on the first step.
Not present on the first step.
Right? Arthritis can be, right? That is one. Why is the patient getting pity on hanging the leg by the side?
Sir, on hanging because of gravity, there is some amount of arterial flow going to that part of the limb, and the substance P wash out.
Substance P wash out is when you walk and it is not related to a substance. But why is it that normally he is having pain, but when he hangs his leg, it's gravity dependent?
Gravity.
Normally, why is that not there? If you have leg ache in a non-arterial disease, you don't get that kind of relief, right? Why is it in an arterial disease you get that relief? Especially in a diabetic. There is something called autoregulation, right? So, whether you stand on your head or stand on your leg, there is a regulation of the lumen. There is a regulation as to how much blood goes into the leg. In arterial disease, your vessel becomes stiff. In diabetes, you also have neuropathy. So that autoregulation is lost. So when you hang your leg, automatically more blood goes into the leg. So it becomes posture dependent rather than the normal way, right? Have you heard of the term guttering of veins?
Yes, sir.
What is guttering of veins?
Normally, like you said, sir, because of the autoregulation, the vein still maintains its tone or caliber. But in cases of PAOD, because the blood supply to the limb is so low that the venous return is also low.
Correct.
So the vein is in a state of collapse.
So how do you demonstrate that? Is it there, if say for instance I am just sitting here, will there be guttering of veins or do you need to demonstrate it?
Sir, in cases of severe ischemia, even at horizontal position, there will be guttering.
What exactly happens? How do you describe? Why is it called guttering? It's like a gutter, right?
Yes, sir.
So when you raise your leg slightly, the area where the vein is becomes like a gutter, right? Because there's less blood going in, so there's less blood coming out.
Yes,
So the moment you raise your leg slightly, the veins immediately empty out and you get a gutter. That's one of the clinical signs of, okay. You have palpated the posterolateral and the popliteal artery.
Yes, sir.
So can you tell me the surface muscle, what are the methods of palpating the popliteal artery?
There are two methods of palpating popliteal artery. One
Because
is
I'll give you a tip for the exam. Okay. When you say, never say 2 or 3, because in a stressful situation, you may say 3 methods and you may not remember the third one.
sir.
Right?
Yes, sir.
So tell me what are the methods of.
So the patient's hip and knee are flexed. Knee is at a 40-degree angle, and the patient's foot is resting on the heel. I insinuate my fingers into the popliteal fossa, and the artery in this particular method is felt against the.
So where is your thumb at that time?
Thumb will be on the tibial tuberosity.
Tibial tuberosity, right.
My 4 fingers will be in the.
What is the other method?
The other
And where are
method
you feeling when you're feeling it in this way, you're feeling it against what?
against tibial organ.
Right. What is the other method?
Other method is patient is lying in prone position with the knee flexed at 90-degree angle, and my 4 fingers are inserted again in the popliteal fossa, and it is felt against the lower femoral cortex.
Correct. So other thing you mentioned is ABI. What is ABI and what are its fallacies?
Ankle brachial index, sir.
How do you do it? How do you do it?
Sir, first we take the systolic pressure in both the upper limbs, and the highest of the systolic pressure is taken as the denominator.
Okay.
And for ankle, the cuff is applied just above the ankle, and once the inflation of the cuff is done with a pencil droplet, we record the time till the flow is returned.
So what is the normal AVI and what are the various values where you start saying it is this or that?
Normal AVI is 1, sir, 1 to 1.3, 0.7 to 0.9 is mild ischemia, 0.6.
So that is called looking at in a claudicant what will it be?
In a claudicant, if it is mild claudication, then it should be between 0.7 to 0.9. If it is moderate, then it will be between 0.4 and 0.6. And if it is severe, it will be less than 0.39.
Critical limb ischemia, right? Correct. So what is the role of hemoglobin here? Why did you say hemoglobin is important?
Sir,
In your lab test, you said hemoglobin is one of the first tests you did, right? So what is the importance of hemoglobin?
hemoglobin is a carrier of oxygen. So already blood supply is low. We want to ensure that the patient is optimized, having adequate levels of hemoglobin, so that to certain extent we can reduce the cellular level.
Can you have a problem the hemoglobin is too high also, especially in smokers?
Yes, sir. It can cause polycythemia can cause a hypercoagulable state.
Correct. I think you virtually answered everything. Yeah. Excellent.
You know about oxygen dissociation curve?
Yes.
What does it say?
As the hemoglobin releases the oxygen, the curve shifts to the left.
So basically, if you have anemia, the oxygen dissociation curve shifts to the left. So what happens is the blood doesn't release the oxygen to the tissues. So therefore, correction of hemoglobin is important.
What is the fallacy of an AVI?
Sir, if the patient is having heavily calcified vessels, then the values are generally falsely raised.
One more tip, that when you are using the Doppler, you can differentiate it, the quality of the signal which you get.
Yes.
So it's either monophasic, low monophasic, high monophasic, or biphasic.
So,
So that also gives you an idea of how severe is the ischemia which is there.
so
And that vessel can be targeted for opening up at a later stage if you're targeting.
yes, sir.
So so you have something called pre-op and post-op. So can you take us through that?
Sir, when the patient was subjected to CT angio, we had found critical stenosis of common iliac artery on the right side with occlusion of external iliac artery and occlusion of the superficial femoral artery, sir. However, because the stenosis or occlusion was not at the origin of the internal iliac artery, we had performed a stage vascularization on the patient, sir, wherein the CIA stenosis was dealt with a POBA and the external iliac and the SFA occlusion was dealt with a bypass graft, sir.
So where did you take the graph from?
Sir, we had used a PTFE graft, sir.
From where? Because your external iliac artery is occluded.
Sir, it was taken from
Because you only opened up the common iliac artery. You haven't done anything for the external iliac artery based on what you said.
I'm sorry, sir, the external iliac artery was also dealt endovascularly, sir.
So only POBA, or did you use a stent also?
No, sir, stent was not used, sir. POBA was.
Any reason why you didn't do this stent?
So I will request my vascular surgeon.
So you did a bypass, right?
Yes, sir.
And you crossed, where did you do it? Did you do it below the knee, above the knee?
Above the knee, sir. We had landed at P1 part of the popliteal artery.
Do you have anything to show after this?
No, sir.
You didn't do the amputation, debridement of the toe?
So we initially, when the patient had presented to us, since his TLC was on the higher side and there was foul swelling discharge, we did a conservative debridement, and followed by revascularization, we had done a proper debridement, transfer the tarsal level, and patient is now doing well.
So you don't have photos in there?
Sorry, sir.
What is the medical management? The surgery is over. So when you discharge the patient, what are the things you will mention on your discharge certificate?
Sir, I would strongly recommend to the patient to stop smoking, sir. And I would start the patient on a gradual exercise program, sir, in which the patient is asked to start walking initially at a pace wherein the claudication is brought about within 3 to 5 minutes, and this first session is for about 35 minutes, and over a period of a few sessions I would increase it by 5 minutes, sir.
Anything else other than that?
Apart from that,
Medication?
I will start the patient on DAPT, sir. And I would also start the patient on Silascosamine and atorvastatin, statins.
What about his glycemic control?
Yes, sir. I would ask the patient to, I would inform the patient to take care of his food, ensure that there are no inadvertent injuries, inspection of the food daily, offloading.
Footwear.
Yes, sir. Offloading in home.
Glycemic control and footwear have to be top of your list.
Yes,
Medicines come after that.
Yes, sir.
One more important issue is that, you know, if you look at the photograph which you said,
Sir.
you could see that there is infection going on the big toe.
Yes, sir.
So even the ball of the toe is infected. So there would be logistic issues about mobilizing the patient immediately on discharge.
Yes, sir.
Because it's unlikely the wounds would have healed.
Yes, sir.
So you need to get the wound also to heal before you start telling him to do ambulance. Otherwise you find that the wound does not heal.
Yes, sir.
Because you have a very small period within which ensuring that your wound does not your restenosis does not take place. And another important thing is you have used PTFE. In an infected situation like this, there is always a risk that the infection, the graft will get infected, especially in the groin area. Because the groin area has a lot of lymph nodes. And when you are taking an incision going to the artery, there is always a chance that graft will get infected.
Yes,
So
sir.
you have to be very careful about that. So good antibiotics, adequate cover is very important. Thank you.
Thank you.
So my patient Mr. X is a 42-year-old gentleman resident of Bhopal, Madhya Pradesh, educated up to graduate level, and he is a soldier by profession, and he belongs to middle class socioeconomic group. He presented to us with a chief complaint of dilated tortuous veins over both legs of 3 years duration. Along with it, he had complaints of discoloration of both legs for 1 year, and an ulcer over the right, this is a type of a right leg of 2 months duration. So he was in a apparent normal state of health 3 years back when he noticed dilated tortuous vein over both legs, which was initially insidious in onset. It was present on the inner aspect of the right leg. Followed by that, he noticed similar findings on the left leg also. The dilated veins became more prominent on prolonged standing and exertion, and they decreased on lying down. It was associated with a dull aching pain, which increased at nights, and he occasionally experienced heaviness and cramps at night as well. It was associated with brownish black discoloration of both leg and feet of 1 year duration. This was also slow to start, progressively increased, and almost spread to the entire circumference of the legs, and associated with itching occasionally. It was also associated with excessive dryness of the legs and feet. Patient also complains of an ulcer over the right leg of 2 months duration. It was insidious in onset, progressively increased in size, and initially it was painful, associated clear discharge, and he has history of similar ulcers in the past over both lower limbs, which healed spontaneously. There is no history of trauma, no history of prolonged immobilization of the limb, no history of fever or constipation. There is no history of any chronic illness, no previous limb or abdominal or pelvic surgery, no history of long-term hospitalization or bed rest. He consumes mixed diet, has normal appetite, he is a reformed smoker. 4 pack years is his total period of smoking, tobacco exposure. He has normal bowel and bladder habits, no known food and drug allergies, and his family history is non-contributory. Patient was conscious, alert, and cooperative. He has mesomorphic build with a BMI of 23.2 kg per meter square. Normal gait. He is well preserved nutritionally. His vitals were stable. The local examination of the right lower limb, the inspection showed the attitude of the limb to be normal. with multiple dilated, tortuous, elongated vein in the GSC and SSV, in the great saphenous vein and short saphenous vein territory. There is hyperpigmentation over the gaiters area, and there is a single active ulcer proximal to the ankle joint on the lateral aspect of the right leg. I'll show it in subsequent slides. And there are multiple healed ulcers over medial aspect of distal 1/3 of the leg and dorsum of the foot. There is no active bleeding or discharge, and saphenopharynx was absent. Local examination of the left lower limb reveals attitude of the limb to be normal with multiple dilated, tortuous, elongated vein in the great saphenous vein territory. There is hyperpigmentation over gaiters area with multiple healed ulcers over distal 1/3 of the leg and dorsum of the foot. There are no active bleeding or discharge, and saphenopharynx was absent in this limb also. There is an ulcer on the right lower limb on the lateral aspect proximal to the ankle joint. Single ulcer, ovoid in shape with sloping edges, and no bleeding, no discharge. He noticed discharge when he came, but on our examination there was no discharge. On palpation, the inspectory findings were confirmed. The local temperature of the distal leg and feet was normal, and there was no tenderness. To continue palpation and perform the special tests of venous disease, we performed Brody Tendelenburg test for both the limbs, and it revealed SFJ and perforator incompetence bilaterally. Multiple tourniquet tests revealed dot, void and Cockett's incompetence on the right side and dot and void incompetence on the left side. And Figran test, we confirmed multiple depressions at the level of perforators. There was no evidence of DVT bilaterally. Human sign and Moses sign was absent, and Perthes test was negative. All the peripheral pulses were felt. They were normal, and on auscultation there was no brewing audible. To conclude, my patient Mr. X is a 42-year-old gentleman resident of Bhopal, Madhya Pradesh, soldier by profession, and presented to us with complaints of dilated tortuous veins of both legs of 3 years duration, with discoloration over gaiters area of both legs and chronic ulcer over right leg. Examination suggested multiple varicose vein bilaterally of lower limbs and bilateral SFG and perforator incompetence associated with features suggestive of chronic venous insufficiency in the form of bilateral lipodermatosclerosis and chronic venous ulcer over right leg. My diagnosis is varicose vein of bilateral lower limb with chronic venous insufficiency. C classification for the right limb is C6E primary, A, S and D, and the pathology to be reflux. VCSS, revised VCSS score for the right limb is 12, and on the left C5, EP, A, S, and RVCSS score of 8 on the left side. Completed the...
You're finished?
Yes, sir.
Okay. So, I'll ask you, one, you said that there is hyperpigmentation in the leg.
Sir.
So, why is there hyperpigmentation in venous disease?
Sir, hyperpigmentation in the leg or in the gaiters area in venous disease is due to increased venous pressure, sir. Increased venous pressure, which results into leaking of the capillaries, and that leads to extravasation of leukocytes and RBCs under the skin, and the degradation leads to hyperpigmentation, degradation of RBCs and hemoglobin.
What causes that black color? What is that black color? Why does extravasation cause black?
Sir, the hematin or the...
so it's hematology, right?
Hematology.
Right. So that is one. The other thing, word you used is gaiters area, right?
Sir.
Why is it called gaiter area? Is it gaiters area or gaiter area?
Sir, gaiter or gaiters are...
What is it actually?
Sir, in the old days, sir, the cavalrymen, they used to wear gaiters over the distal part of the leg to hold the horse and
To kick the horse.
to
Yeah.
protect their medial aspect of the legs. Sir, gaiters were worn, sir.
Correct. Have you asked for a history of limb swelling, DVT?
Yes, sir. I asked him whether there was any previous history of swelling of the limb or excruciating pain of the calf region, sir.
In the past.
In the past, sir.
Why is that important?
Sir, one varicose vein could be secondary due to DVT, sir.
So why is it important to know whether it's primary or secondary?
Sir, in DVT, if the status of the deep veins, if they are not recanalized completely, we will not offer him surgery for the superficial veins, sir, because they might be the only veins which are draining that limb, sir. So we cannot occlude them, sir.
And you used a tourniquet test, right?
Yes, sir.
So how many tourniquets would you carry to the exam?
Sir, in a hospital setting, sir.
No, if you're going for an exam as a PG, appearing for your MS exit exam, you go with a tourniquet, right?
Sir.
I don't know why people ask in the exam still do the tourniquet because it's obsolete, but it is good to know because people still ask in the exam. So how many tourniquet do you need, ideally?
Ideally, sir, 4.
Why 4? Tell me where you will apply it.
Sir, first we'll apply at the just distal to the sacrophumoral junction, sir. Then one above the knee joint, one below the knee joint, and one above the ankle joint,
So
sir.
why is that so?
Sir, because of one just distal to the sacrophumoral junction, because the incompetence of the junction we have to rule out, sir. Then the location of the perforators or the classically described perforators are such, sir.
So how many perforators are there in the leg? Just a guess.
Sir,
How many perforators would there be in there?
40 plus.
40 plus can be 10,000 also.
Sir,
There are about 205
sir.
described perforators which are
Sir.
okay. And have you done the Fagan's test? Have you heard of Fagan's test?
Yes, sir.
Yeah. So you mentioned the Fagan word?
Yes, sir.
Did you use the Fagan?
Sir.
Okay. So now you got this diagnosis.
Sir.
What are you going to do next?
Sir, I will follow up with the color Doppler venous for the superficial and deep venous system for both the.
How would a color Doppler test read? Ideally, if you're sending someone for a color Doppler
Sir.
test, it's a duplex scan, what you call it.
Duplex, sir.
So, what are the things you would want as a surgeon to be mentioned nicely in a Doppler report for you to plan the next step?
Sir.
What would you like in that? You must have read a Doppler report.
Sir, sir.
So, just take us through what are the things that are written in a Doppler.
No, sir. Sir, I know the report we have. This patient is a post-op patient, sir.
Yeah, so just tell me what are the things as a surgeon what you would want to know.
Sir, we want to know the status of both the deep and superficial system. So, in deep system, we'll check for the patency of the vein and any evidence of DVT. For patency of vein, we'll check for the condition of the walls, wall-to-wall flow, any contents, that is hypoechoic or echogenicity of the vein, sir, and whether there is any reflux in the deep system or not. Then, if
Superficial system.
so in superficial system, sir, we'll check for the reflux at saphenofemoral junction and saphenopopliteal junction, because saphenopopliteal junction we cannot assess in a clinical examination because of variable anatomy, sir. Then once we have checked the reflux, we'll like to know the size of the vein, sir.
Would you like to know the duration of reflex also? Is it important to know? Duration? It's important to know. So the prolonged reflux of more than so many milliseconds. Okay. What else?
The diameter of the vein, sir.
Okay.
If there is any excessive tortuosity of the veins, and the anatomy of the veins, sir, whether it is I type, S type, or H type.
Anything else? You mentioned the
The
perforators.
perforators, competence of the or incompetence of the perforators.
What would you want to know as a significant perforator? To call a perforator as significant, you get 205. We're not going to tackle all 205 of them, right? So, when would you call a perforator reflux as significant? Would you treat all the perforators? You don't treat all the perforators, right? You treat some perforators. So, which are the perforators as a surgeon you would want to treat based on your duplex approach?
So perforators associated with the dilated tortuous veins or the in the region of the dilated tortuous veins with the incompetence and
Anywhere in the leg?
elevated time.
Anywhere in the leg?
Sir, along the GSC and SSC.
GSV, SSV is long, right? So if there are 10 perforators, would you be ligating or burning all of them?
No, sir, below the knee, below and above, just above the knee, 5 to 10 centimeters above the knee and below the knee.
No. There are 3 criteria for that. One is it has to be peri-ulcer. Second, it has to be more than 3.5 millimeter or more. And it should have a reflux of more than 0.5 milliseconds. Right? Otherwise, we just go aimlessly ligating 100 perforators. Right? So, a significant perforator, so if you have an ulcer, as in this case, and there is a peri-ulcer perforator, which is more than 3.5 millimeters, and refluxing more, so all that you need in your duplex temperature.
Right.
Okay, how will you treat it? Final question. How will you treat this case?
Sir, we offered endovenous procedure for this patient. Sir, we performed radiofrequency ablation of the GSC and we performed multiple phlebectomies.
What are the treatments you know as a general surgeon?
Sir,
Available modalities in general, theoretically, that are available to treat a varicose vein like
sir, there are open surgeries and minimally invasive or endovenous procedures. Sir. In open surgery, ligation of the FFJ and stripping of the vein, and there can be ligation of the FPJ also, sir, for incompetent of the. Sir,
how much of the vein will you strip?
sir, in
From joint to toe?
sir, in our center we usually go just above the knee joint. Sir.
Why is that? It's not wrong, but why? Generally, we don't go one hand's breadth below the knee, we don't strip the vein. Why is that? Surely there is a reason, right? There's something very closely adherent to the vein below that level. What is that structure?
Sir, the saphenous nerve.
Saphenous nerve. So what are the other modalities? One is ligation and stripping. You said the other minimally invasive. What are the minimally invasive?
Sir, there are sir, endovenous procedures such as endovenous laser ablation and radiofrequency ablation. Then for perforators, we have foam sclerotherapy or use of cyanocrylate glue for perforator incompetence treatment.
Okay. So for your exam, you say there are open and minimally invasive. Minimally invasive are thermal and non-thermal.
I think this classification, the way you have given it, is complete. What is missing? So when you get something like this, when you say C, you had large veins, so it becomes C2.
Sir.
You have swelling, so it becomes comma 3. There's pigmentation, so 4A. And then you put 6 or 5. So that gives you complete clinical picture.
Right.
P is fine.
Sir.
S also, S2, P, 17 or 18.
Yes, sir.
17 is above, 18 is below.
Right,
So that becomes, that's clear.
sir.
So one more thing I'd like to ask you, when you looked at both the legs,
Sir.
there's something that you need to look at which will give you an idea also that this could be post-thrombotic. Anything, what is it that would give you that kind of an idea that yes, this could be post-thrombotic?
Sir, there will be a difference in the girth of the limb.
Right. So immediately when you see that there is a difference in size between the two legs, think that there is post-thrombotic. Similarly, what Sir asked you about Doppler or duplex scan. When you look at deep veins, which veins that you look at?
Sir, common femoral vein, popliteal vein, and
So there is one vein which you must never forget to look at, highlight. Because many Doppler reports will start only from the ground and they fail to go up. The second important thing is also see to it that they examine the patient both in lying down as well as standing position. Because many of these veins you might not be able to diagnose the reflux, but in standing they will stand out.
Sir.
How will you manage the ulcer? There's still an ulcer there.
Sir.
So how will you manage the ulcer?
Sir, there are two approaches, sir. First, we can treat the ulcer first using Disgard's regimen, and once the ulcer, sir, Disgard's regimen contributes of sir, patient education, limb elevation, elastic compression, and revaluation. Sir.
What is the other method?
Sir, other method, we can, if the active ulcer is not infected, we can directly go for a procedure for the incompetent veins, the varicose vein.
All that is done after care.
Sir, regular assessment of the.
Will it heal on its own? Is there any role of stockings?
Sir,
To somebody out there
Sir.
with the stockings.
the stockings are advised post surgery for patients which had ulcers.
What type of stockings?
Sir, class 2 compression stockings will be sufficient for this case.
There is one very important word in that. Class 2 dash stockings.
Compression.
One more word. Between class 2 and compression. Graduated. Because there is a group of stockings which are more tight up and less tight down.
Sir.
The graduated compression should be more tight down and less tight down.
Sir.
Good morning, friends. After some study, let's get down to some excitement as to the real world, what's going on outside your area here. I bring greetings from the Vascular and Endovascular Surgical Society of Maharashtra and on behalf of the Vascular Society of India. Today, as you know, is amputation prevention. And we are here to educate the public about vascular diseases and promote early detection and treatment. As I mentioned with a lot of friends, I have a deep connect with the armed forces, having studied in a Fauji school, and there's a picture of, those of you who are in the Fauj know who this is, a good school buddy of mine. So before we start, I'd like to slightly rephrase what we're going to talk about. The question we should address is, should vascular surgeons be the first on call for vascular diseases? Right, so that is, and what I'll do is, we'll discuss a couple of cases, and then at the end of the presentation you can take a call and whether the question that I've asked right now is valid or not. So this is an 80-year-old male, diabetic, smoker. So he's a smoker, hypertensive, otherwise fit and well. And he's otherwise fit and well. And he walked into the OPD with a foot, as you can see here. He has a wet gangrene of the second toe, severe pain and almost unbearable cold leg, edema, foul smelling smell. There's some sensory loss, motor was normal, and when we felt the pulse, the femoral was normal, the popliteal was weak, and the antitibial and the posterior were absent. The other opposite leg was normal. It comes with certain labs, and as you can see there, the WBC is slightly raised, but otherwise is good. We also had a culture report which showed proteus growth, which explained the stench. He had also come with a color Doppler report done elsewhere, which said there is extensive atherosclerotic blockages below the knee, and all the tibial vessels are occluded right down to the ankle. So with this kind of report on a gangrenous foot, he had come to us. He also had an angiography done elsewhere, and as you can see, up to the knee things are good, and then after that is just a leash of nondescript vessels. At least that's what it seemed. The report said there are no major vessels seen, and post this, the patient was labeled as non-reconstructible distal tibial vessel disease, and as very often we are taught in general surgery that below the knee if there's something like this, it's just amputation. So this guy had already been treated with lot of dressings and then he's sent for a hyperbaric oxygen, right? Which, is, I feel, overhyped, because how hyperbaric oxygen is not, it doesn't go and hit the tissue right away. It has to be breathed, it has to go through the blood vessels, it has to reach the tissue and then it has to regenerate the tissue. So if there's no blood supply, hyperbaric oxygen is a sham, right? So that's the basic. And so, like it is, send it to the vascular surgeon for an amputation. So that's what he came for. Now what are the options in this case? Best medical management and hyperbaric oxygen, which is already got. Just top off the two and give him hyperbaric oxygen is not going to work because the blood supply is not there. He's 80 plus, you ampute his leg, but ampute where? He's going to be, or is there a surgery, right? So in this case, we planned for a femoral tibial bypass. We said, let's open the ankle and see if there is something we can see. He has a good vein, we'll do a bypass into the ankle. And if it's not there, we'll probably amputate it. So we did a Doppler and we found a good conduit, a vein. So this guy had a reverse great saphenous vein bypass from his femoral, as you can see in this picture. And we knocked off his toe, put in a patch of graft, and finally the wound has healed. So the message from this is that just because you don't have a runoff in the leg, the conventional teaching in general surgery is that if there is nothing below the knee, it's amputation. Either you do an angiography, either it's angioplasty or amputation. That's not the case. Just as in a cardiac surgery, despite all the interventions, you still have people getting CABGs done. Right? It's not that you have stents, so CABG. The same thing applies to the leg. You will have a subset of patients who are good for medical management, some who will be for angioplasty, but still there will be people who will do well with a bypass. So that's not out of the window as is made to be believed very often, right? That you can't do an angioplasty, so it's an amputation. That doesn't hold good. Another interesting case. This guy is a 60-year-old national cricketer of some repute. He is now a Ranji coach with one of the state Ranji Trophy teams. Very pleasant guy. Unfortunately, he belongs to my generation of guys where physical fitness was not the big thing in cricket, right? He's not in the Virat Kohli era. So he's a smoker, right? He used to smoke a lot, non-diabetic, hypertensive, repeated injuries during his career. And he had a non-healing wound in the ankle. This is what I got from his history over the phone from one of the members of the BCCI who had called me. And the story goes that he had prominent veins in the thigh. And I said, send over the picture, and he sent me this picture. Right, so this was the picture that I got on a WhatsApp. Now this ulcer could be either dermatological, venous, neuropathic, traumatic, arterial, it could be anything, right? You need to understand that just because it's in a gated area, it doesn't mean it's a venous ulcer. So as you have rightly shown, whether even if it's obvious that it's a venous ulcer, you need to feel the pulse, right? Because he may have a coexisting arterial disease and you give a tight compression and you'll find that a small ulcer has now become large when you open the bandage, right? And that's exactly what happened to him. What he had already got done, he had got a venous Doppler which showed a mild reflux, varicose veins labeled. He got a laser done, so all visible veins were ablated. And then he got the tight bandage, severe pain, ulcer became larger, his wheelchair bound. I said, you come over. He said, I can't, I need to catch a cab because I'm wheelchair bound. So what did we miss here? Before I tell you what happened actually, what did we miss here? Any of you, budding surgeons can answer that. What did we miss here? Nobody felt the pulse. He's a 60-year-old smoker and nobody checked the pulse. He just saw the veins and burnt everything. Right? The arterial Doppler showed a long femoral artery, right, disease. He needed a bypass, but no vein was now available. Right? So everything had been burnt. So one simple thing that was to be done was not done. And you know, synthetic drugs, patency is not good, as good as a available vein. So he needed a solution which was a very much what we call an Indian scenario situation, devised by an Indian, what is called subintimal angioplasty, which is effective, economical, it's easy to learn, and 80% reduction of pain day 1, day 2 he went on walking, and he's recovered well. So the moral of the story is, when you have a new hammer, everything looks like a nail. You have a new laser machine, everything looks like varicose veins. So don't fall into the trap. Also, the important lesson you learn is feel the pulse always. Even if it's obviously a venous disease, always feel the pulse. It costs nothing. So this is the healed ulcer. Okay? Simple tips. Okay, this is a spot diagnosis. This is a 47-year-old guy. As you can see, a classical above the medial malleolus, gaiter area, not very painful. 5 years, pigmentation increasing. This time the pulses are felt, good pulses. But the problem is that this guy has had a laser surgery done for varicose veins 3 years ago by Dr. X. Yeah? But Dr. X cannot explain why the ulcer is not going away despite the varicose vein surgery. He says it's bad luck. Right? Luck doesn't play really a role in science, right? So he said, I'll do a Doppler for your leg, and he showed, see, all your veins are ablated. I have done a good job. It's not my fault. So what would you do next? And I'm sure you see a lot of these cases. You know, those of you who are dealing with wounds in the leg, you'll see a lot of these with heavy pigmentation. Sometimes ulcers, sometimes no ulcers. You know, champagne bottle legs. Everything is not varicose veins, right? So as Dr. Pai mentioned briefly in your presentation, sometimes you can have the iliac vein which is compressed. Okay, so if things are not improving with a regular varicose veins therapy, you have to suspect either it's a May Thurner. There are 4 places where the iliac vein can get compressed. The best way to diagnose this is with an intravascular ultrasound, which is freely available in most cities in India today. It just involves a catheter the size of a ballpoint refill, and you can get to see the inside, and it gives you a calculation as to how much the compression is. And we can put in stents, and patient can go home the next day or maybe the same day sometimes. So 3 months down the line, you can get an ulcer that heals by science, not by luck. Right? So the take-home message here is all venous diseases are not varicose veins, and laser is not the solution for all venous diseases, right? Sometimes you also need to be careful about reports like this, right? Venacil is the new kid on the block, but sometimes you find that, you know, we are in a generation where everything is instant result, and some of these reports read as instant result with Venacil. So all roads don't lead to Rome. Similarly, you know, Venacil is not the magic. You have to be careful. And you just see this guy. Sometimes, you know, clinical acumen is dying. You know, we present cases, but sometimes we know the treatment and we know we have the skills, but the clinical acumen is something which we are losing out on more and more. We are depending on investigative tools. If you see this guy has been having ulcers. He's from Bhopal. Somebody who's had ulcers for years with bandages, and see the ankle. This guy's been posted for a Venacil, and something was not right, and so we did a 2D echo, and you can see his EF is close to 20%, severe LV dysfunction, right heart failure, pulmonary hypertension. Right? So you can get a venous ulcer due to this, so don't discount it. Don't get into the varicose veins mode for all venous diseases. Sometimes what the mind doesn't know, the eyes cannot see. So here's one more example. A young male, 36 years, non-smoker, no diabetic, no comorbidities. He's an air traffic controller even today in Mumbai. Right? Why he's relevant to people of people like you who are in the forces is because for the ATCs, the medical examination is done in the Army Hospital or the Air Force, in Bangalore, right? So he had gone there, and one of my colleagues there, Dr. Bembu Anand, he's the person who actually sent this guy to me. He's an air traffic controller still operating in Mumbai. He has a history 3 months ago for absent pulse in the right wrist with discomfort in the forearm on exertion. Right? This was his original problem. And severe constant pain. Right now he says he has constant pain in his right hand interfering with his day-to-day activity, and he says that कुछ तो यहाँ अकड़ रहा है in my axilla, कुछ तो I can feel, कुछ तो चुभ रहा है, right? He had absent pulses in the right hand, but the limb was viable and warm. He had brought some X-rays and angios, and when you see here the angio, it shows that, if I can orient you, you can see here there is a segment of artery this is the shoulder joint, and there is a segment of artery missing here. This is normal, this is no, so somewhere in the third part of the subclavian, first part of the axillary, here there is a segment missing, right? So this patient had undergone a balloon angioplasty of the affected segment of axillary artery. During angioplasty, obviously the artery dissected, so he had a stent put inside. He is a young chap, no comorbidities. Commonly, we think arterial disease means atherosclerosis. So there is a temptation to balloon everything and stent, but in the process the artery dissected and needed a stent. Now post-procedure, what was an intermittent claudication has now become a permanent thing. And is interfering, and you can understand an ATC who is, is such a vital cog in our day-to-day life, at least for people like us who travel. Instead of looking at what flight's taking off, his mind is now in his axilla. So he was then sent to R&R and told, you get a medical examination, there's something you're not fit. And from there he was sent to us, and you can see here, this is what was poking in, right? There is a stent there, half inside the chest, half poking into his axilla. And we did a CT angio, and you can see the stent is here, but beyond that now again there is a blockage which is beyond that. Right? So what's wrong? What went wrong here? Can any of you guess what went wrong here? This guy is not a smoker, he's 32, he's fit and well. So what could be the possible cause of an arterial disease? All arterial disease is not atherosclerosis, right? That is the message I'd like to share. His CRP was extremely high. We got his PET done, multiple areas of uptake. He is aorta arteritis. He's put on mycophenolate, steroids. He's totally asymptomatic. He sends me Diwali greetings. But whenever he comes, he says, "Sir, magar pulse nahi feel ho raha." Right? But he's fit. He's still performing in the ATC Mumbai airport. But the moral of the story is that everything is not atherosclerosis. Everything doesn't need a stent. Sometimes science loses out to commerce. Right? As vascular surgeons, we see this quite often. Claudication, smoker, short segment femoral artery block, sedentary job. He's a high profile executive in Adani Electricity. Right? Chauffeur driven car. So claudication treatment is a relative indication. Rest pain, absolute indication. Claudication is relative indication. So 100-meter claudication in a smoker, you tell him stop smoking, control your diabetes, do exercise, and your claudication distance will improve. So what are the two options? You have best medical management, and as you rightly said, put him on DAPT, statins, or the other option is putting in the best stent, the most expensive stent into the femoral artery, right? Unfortunately, this gentleman, somehow had a big fat insurance, and he went for the latter option. He got a Supera and the expensive stents. Stent occluded on table, got a thrombolysis. A lot of muck went down, and he came to us with a threatened limb. right? His bill had already come to 14 lakhs. His insurance was 10 lakhs. He is a high profile guy, who would probably be a deluxe room guy. He comes and says, please admit me in the general ward, because I can't afford it anymore, right? So all we needed to do was remove the stent and repair the artery, and we could salvage the leg, right? So the whole purpose of telling you this is that there is a very good and strong indication for good medical management. Everything doesn't need a procedure, right? So medical management is something which is still very much useful and potent in the armamentarium, which we are probably underutilizing very often. Okay, so just to put this into context, okay, you all know what this is. It's the Bofors gun. It's meant for the tiger hill, right? It's not meant for a mosquito. You don't kill a mosquito with a Bofors gun. Okay? So we don't shoot a mosquito with a Bofors gun. But here is this story. This is a 28-year-old auto driver. He had a sudden onset limb ischemia. What a Doppler done. 3 centimeter clot in the brachial artery. Okay, it's something which is a cakewalk for even a basic general surgery resident. A basic simple embolectomy costs about $1.5 lakh at my place, and generally you get 100% outcome. Right? It's a simple, absolute basic surgery that you learn in your first year in vascular surgery, and you get a 100% cure. But there's a lot of fear mongering, diverted elsewhere, lack of expertise, this guy, that guy, vascular surgeons, and all that. And he landed up with this. So when he came to our OPD, somebody had tried a very high-end, expensive tool, an angiojet, to try and suck out this clot, right? What you could compare with a Bofors gun. And everything had fragmented, gone down, shut down the arteries, thrombolysis, suction, poking, fiddling, lysis, and now his hand is gone. He's just come with his hand like this now. He's an auto rickshaw driver. So what was a simple story has now become complicated. This guy had to sell his house and his bill was 18 lakhs. Right? So one small judgment error is what has led to this. So the take-home message in conclusion is, when a vascular disease is treated by a vascular surgeon, you get a good history, a proper clinical examination, proper investigations, and then you segregate into surgical, intervention, medical management, when to do what, when not to do what. So as vascular surgeons, we treat the patient, we don't treat the angiogram. And to put it in context, I take you a little bit into a religious background. I don't know how many of you would be able to identify. Can you identify these three? Anyone of you? Anirudh? Most religious guy? Do you know who these three are? One is Saraswati. Okay. Who's that? Vishwakarma. And the third is Lakshmi. So knowledge, craftsmanship, and then wealth. That's the correct segment, right? So the correct sequence is science, then art, and then commerce. Unfortunately, it doesn't go that way very often, but this is the correct way out. So to conclude, I put my first question back again. Should a vascular surgeon be first on call for vascular diseases? That is for you to judge. Okay? Thank you.
Thank you, sir. We'll start with the next one, with Dr. Ramesh.
Thank you, Dr. Rakesh Jha, for everything, the wonderful CME. I just start. The topic today given to me is intraoperative vascular mishaps. Now, all surgeons have some problems, had some problems in the past. Now, just before I go ahead, a young person walking to the casualty with a sharp injury to the neck. vitals are stable. So what do you think this is? I will answer this in my later slides. So by definition, an arterial vascular injury is defined as an injury sustained to main blood vessels during surgical or percutaneous intervention requiring vascular repair. The common causes is blunt injury by retraction or by stretching the tissues can cause blunt injury to the blood vessels. They can be penetrating injury like while you do a laparoscopic, trying to put a port, or failure to identify a major blood vessels during dissection. Like one of my first patients, whereas one of my first emergencies, the oncosurgeon had ligated the subclavian artery and the anesthetic realized is the pulse is missing or the skin had already changed. So failure to identify the major blood vessels, injury during dissections and cannulation of arteries. We had lots and lots of patients who had even cannulation of subclavian artery trying to put a subclavian venous access. Even HD cap was put in the subclavian arteries. Now the common sites are neck, supraclavicular area, axillary, upper limb, abdomen, groin and lower limbs. So before first, whenever patient you have arteriogenic bleeding, the first thing to look for is the type of bleeding, whether it's arterial or a venous. Assist, and if the situation demands, call for help. Arrange adequate units of blood and ask for help. Till the help is arrived, only apply pressure. Don't try to hold the blood vessels if you are not able to identify the type of bleeding. Venous bleeding to a major vessel is difficult to localize because they just fill. And if you try to catch this blood vessel, it is going to keep on damaging the tissues, the surrounding area, and it will be very difficult to control such bleedings. The arterial bleeding tends to retract, so if you suspect arterial bleeding, search for the retracted ends because once the patient is shifted to the ward, we can start bleeding from those ends. So before I go ahead, these are some of the vascular instruments which we use. Bulldog clamps. I think all OTs should have, I think we have over here, but in where we practice in nursing homes, we don't have all the clamps available. So we try to keep the bulldog clamps, deep HS forceps, satin skis, and needle holders. So for venous pressure, the idea is to give pressure. For venous bleeding, pressure first, ligation, and if required for a major vessel like iliac or IVC, repair. For arterial, control, repair, ligation and bypass, or with the interposition graft. If the defect is more, then you require an interposition vein graft. So these are the suture materials. We never use taper cutting or reverse cutting. It's always two needles with the taper cutting or round body needles. Generally 5-0, 6-0 or 7-0 sutures are used. How to control a bleeding? Either with a loop or with a clamp or ligating, or sometimes if the bleeding, if you are not able to control the bleeding, you can use a Fogarty catheters and clamp the vessels from inside. So for arterial proximal control first, distal control is required, and if the bleeding is from the forearm or the limbs, you can use a tourniquet to control the arterial bleeding. Exposure on control of arteries is important, and for the venous, local pressure and if possible, control of the distal and proximal control. So ligation of all major vessels, always 2-stage. For the repair, you never do end-to-end repair. There will always be some bursting effect. So you have to expose the artery, take a transverse incision and then do a repair. So your bursting effect is not there. This is very important when you repair a end-to-end artery. And if you have a defect in just the wall, then you have to put a patch to prevent again keeping of the or narrowing of the vein of the artery. Always remember to give repairing when you are planning to clamp the arteries. Most of us most of the surgeons are afraid to give heparin because there is already loss of blood and bleeding. But if you don't give heparin, you are going to have thrombosis in the major blood vessels, and that can cause more problems. So remember to give heparin. Generally we give 5,000 units heparin before clamping. But if you are already clamped the vessel, you can give heparin and then see to it that there is no fresh thrombus in that. So we all know the vascular anatomy. You can read it from your books. Always anticipate complications for any major or a new surgery which you are not familiar with. Anticipate complications and keep the things ready. So most common injuries is for the neck and supraclavicular surgeries which you find is during thyroid, parathyroid, subclavicular lymph node dissection, very common, central vein catheter or tumor surgeries. So the common set of injury is subclavian or the jugulars, carotids or jugulars. So this is how a carotid looks intraoperatively. For a carotid, if the incision is not, we prefer parallel incision to the vessel walls, but wherever the patient is called to us during the surgery, we just extend those incisions and try to control the distal and the proximal end of the blood vessels. Important to remember for carotid is injury to the nerves. In your zeal to try to control this bleeding, you will just go on clamping the blood vessels. So there is a high chance that you will damage the main blood vessels. Remember, the carotid you have to maintain the circulation to the brain. Exposure of the subclavian, various incisions for exposure of subclavian vessels. Remember, for subclavian there is chance of damage to splenic nerve, apex to the lungs, lung apex and recurrent angular nerves can get damaged, so you have to take care while dissecting this area. Axillary lymph node dissections is common cause of breast surgeries, can cause damage to the axillary vessels. During breast surgeries, you can, while dissecting the axilla, you can damage the arteries or the veins. So if once the veins or arteries are damaged, you have to take control in the subclavian area. So control of subclavian arteries is important. In upper limb, the chances, the common cause for injuries during ganglia surgeries or lipoma surgeries. So this is a common site. My first injury, vascular injury, when I was doing was during ganglion surgery. I damaged the radial artery and we had to call a surgeon to do the radial artery repair. So if you are doing a surgery in the forearm, you can always do a Allen's test where you compress both the vessels, the radial and the ulnar, and then release one of the vessels and see the circulation is maintained. The same thing you do with the compression of the radial artery. So for exposure, be parallel to the radial arteries, or the incision has to be parallel to all the major blood vessels. Abdomen, there are multiple surgeries which can got damage to the blood vessels. All vessels are retroperitoneum, so exposure is very important. If the injury is below the bifurcation, this is the incision which we take. And if the injury is in the renals or above, then you have to go transthoracoabdominal incision, where you have to expose the supraclavicular, supraciliac aorta. So one of the examples is where you can damage the celiac arteries, then you have to expose the transthoracoabdominal incision and take control of the supraciliac or descending aorta. This is an example of thoracoabdominal incision exposure. Then lower limbs, common injuries, hernia, lymph node dissection, tumors. I just rush through this. And we can do a multi-position vein graft. This is just an example of the repair. For a femoral artery, if you don't have a vein graft, then you have to use a synthetic PTFE graft. Any idea what is this? Anyone? iliac vein. So they were trying to do a valvotomy. I think it was 2-month-old child. They were doing a valvotomy, and see the size of the device. The whole iliac artery got damaged, and while removing the whole artery came out with the device. Fortunately, the child did well. There was no any lifelong damage to the legs. So his swelling was less. Collateral circulation took care of this. So coming to our first slide, what is this? What do you think this is? So it turned out that he had an injury to the aorta, and he had to repair by doing a thoracotomy. So in conclusion, complications are common with this surgery. It is important to identify and treat on time, and there is no shame in calling for help. In my view, managing complications is more important than knowing how to operate. Thank you.
Thank you, sir. The next topic is by Dr. Marcos. He is a consultant anesthetist who is trained based on his AA from stage 2.
So I am Marcos. So why is it so important, pain? Like Dr. Shekhar had mentioned regarding a patient whose mind was in his axilla. Now this gentleman, does anybody know who this guy is? He also came to know yesterday. Yeah, so he is King Henry VIII. Now what happened is that this guy is having chronic pain related disorders. He was suffering a lot. He put on a lot of weight. At that time there were no vascular surgeons, not even at all, like we have in Mumbai. So his mental status was also affected, they say. He grew obese, he could not move. Finally the end result was he took very bad decisions with a lot of impulsive. The Roman Catholic Church got disconnected from the British or the English rulers, and it changed the course of Europe. So pain is very important. A man in pain can create a lot of problems, and more so a man or a woman with a vascular disease. So that's what we are interested in today. No disclosures. So prior to addressing pain, we should know how pain happens in these diseases. So we all know it's a fifth vital sign and all, but the pathophysiology of pain in vascular disorders are multi-pronged. As you can see in this image, there is nociceptive pain, neuropathic pain, and inflammatory pain. All three are acting at the same time. It's not just one fiber like C fiber or let's say your A delta fiber firing and patient is having pain. So this concept should be very clear. It's a multi-pronged attack on the patient. In venous diseases, it's similar only, but mainly due to stasis and some amount of stretch and pressure on the vascular. So now I went and did a literature research as to what's new, what has come out new regarding management of pain in these patients. So in Journal of Vascular Surgery, the almanac of all vascular surgeons, this article was published in July 25, and in Circulation regarding peripheral arterial disease, this article was published in March 25. So we will discuss very briefly. Next 5 minutes is a while to stop the presentation, so don't worry. My focus is on somewhere specific. How to manage the pain in OPD. This goes out to all my junior residents and the young doctors here. These patients, pain can be an issue in OPD. Second, what I practice generally. My presence is not generally in the first and the third segment. My practice is generally in the intraoperative or the perioperative pain. And third, post-surgery pain, which is where I like to focus today. So in OPD pre-surgery, routine stuff you have to do. WHO ladder. You escalate the ladder. You start with one drug. It can be something as simple as an acetaminophen together with an NSAID. Slowly build up. There are multiple options. We'll discuss about it later also. But ladder approach is what you should know. In addition to that, as previous speakers have mentioned, diabetes control is of utmost care. Weight control is of utmost care. physical therapy, not physiotherapy, physical therapy and nutrition. This also helps. So, escalate the ladder and also think about the other things that can be controlled. Regarding perioperative pain management, many times this patient come to us, we go give a spinal, let's say an epidural, kaboom, थोड़े दिन के लिए infusion चलाया, that's the end of it. But yes, what the recent thinking is, there should be a pain control team, and you should tell the patient what is the plan for his pain management, an individualized pain management. So he is aware कि हाँ यार post operatively मेरे साथ ये होगा. पहले there will be something inside my bag that will help me out. Then they will change over me to some oral medications. Once the patient knows that I will be taken care, then they are much more comfortable. Second, the flavor of the day, multimodal analgesia, maybe last decade. You don't want to give any drug in excess. You want to mix and match. So multiple options are available: acetaminophen, NSAID, opioid, gabapentinoids, lidocaine patches. Most of them are available on the trolley behind you. The company vendors are also brought most of them. So all these drugs you can use. In addition to that, early mobilization after surgery, appropriate nutrition and physiotherapy. Then there is no anesthesia technique of choice. Epidural is preferable in severe COPD patients, patients having some cardiac issues, major abdominal surgery like an open abdominal aneurysm repair. Definitely an epidural helps. And opioid dependent patients. Maybe not in this, I'm not sure about Maharashtra, but there are several case reports from PJ Chandigarh and all, wherein a lot of vascular surgery cases had opioid dependence now. So they found it very difficult to manage this patient. So epidural might be the cornerstone in such patients. Maybe in the future, we might also land up in such a thing. Now, long-acting opioids, morphine and all, try to avoid it. Fentanyl is slightly better. Even remifentanil is there, but the problem with a drug like remifentanil, it has got its own set of issues. Once you stop the drug, the rebound pain is much more. So I think practically fentanyl is what is much better. Then lesser doses. Don't give high doses during the surgery and all. But this all concept of many seminars and conferences, they say opioid-free anesthesia, as if they are trying to tell you you can do a case without opioid. Especially in vascular surgery, it's not possible. You can reduce it. Even if you add ketamine, there was a trial conducted, podcast trial. What they found is that with ketamine, patients had a lot of hallucinations in the post-operative period. So maybe yes, you should reduce the opioid, but to completely get over it, it's not possible. Interfacial plane blocks. A lot of talk regarding erector spinae plane block and paravertebral block is useful, but interfacial plane blocks, still the evidence is plus minus. A place where maybe some of you can do research. Paravertebral block, the surgeons can give, especially if it's a wide excision, they can themselves place a paravertebral block. The catheter can be placed inside. The benefit is slightly better than epidural in the sense that the amount of hypertension and all is slightly less than the paravertebral block. Now, coming on to specific cases, I presume that this was the vascular surgeons here. So, in an EVAR or an open aneurysm repair, so in EVAR, try to avoid a femoral cut down. Obviously, the pain management is less than. Use a percutaneous approach. And even doing an EVAR under local anesthesia and slight amount of sedation, it has been shown that there is decreased length of stay in the hospital. So you need not give GA all the time. You can even manage like this. And the multi-pronged approach, as mentioned there. In an open aneurysm repair, the commonest mistake that is done, that many people put an epidural, but they put an epidural very low. You have to have a thoracic epidural. There is no doubt about it. The thoracic epidural should be sited at T6 to T9 in a catheter congruent manner. Regarding lower extremity amputation, phantom limb pain is a reality and there is no evidence that an early epidural will help. Yes, it might help you during the initial period, but no. Peritoneal catheters, rather putting a catheter right in adjacent to the nerve, can reduce the consumption of opioids by 40%. Epidural catheters are the same. You can place these same catheters, or even certain companies have got contiplex catheters. These are known to be safe around the nerves. You can put these catheters and you can reduce the opioid consumption. This is something last line I read. I don't have any idea about this. What they have written is that targeted muscle innervation at the time of amputation. I suppose maybe the surgeons can give us some idea on this, may be of use. This also reduces the neuroma and the phantom limb pain. Yeah, regarding bypass procedures, again, no benefit of any single technique. Lower extremity venous procedures for the trainees, tumescent anesthesia is an excellent option. 450 ml of your saline with let's say 25 ml or 2% with 1:2 lag plus some amount of 5 to 6 ml of 8.5% bicarbonate. It works wonders. It's very helpful, especially in all these lower limb venous procedures. Now, an area of continuing research maybe of interest in the coming years is spinal cord stimulation. The cost, I believe, in Bombay is around 12 to 15 lakhs. In government setup, if we do it, maybe I have not seen it being done in Chitram, but what I have heard is that it comes to 9 lakhs or something. So if it's a non-operable or failed operative vascular disease, what they are mentioning is that the JVS article says that it even improves the healing of the skin ulcerations and possible limb salvage in the long duration. So something interesting. Regarding thromboangiitis obliterans, stop smoking. All the drugs that we generally give, clopid, cilostazol, pentoxifenone, there's limited data to actually say that it's useful. Now this is what I actually want to conclude. Chronic pain. Many times what happens is that we take them for surgery, we manage them, and we leave them. They only meet the vascular surgeon in the OPD follow-up. And vascular surgeon, they diligently follow them up without realizing that many of these patients have got a symptomatology of 6 months to 12 months prior to even presenting to you, the vascular surgeon, for a procedure. And chronic pain has already set in. Now, gate theory of MedSac is what all residents here should understand. So there is the spinal cord. So there are two types of neurons. What is an inhibitory neuron? One is a projector neuron, which is the brain. So there is a gate here. Think of it as a gate. So there are large fibers and small fibers. Large fiber is A beta. So when a large fiber, is stimulated by touch or vibration, both the inhibitory interneuron and the projector neuron are stimulated, which causes the gate to close. No pain stimulus can go ahead. But in a normal routine scenario of pain, when the small fibers, C fibers and the A beta fibers are stimulated, inhibitory interneuron does not work. Projector neuron sends the signal ahead and the patient feels the pain. After some time, there is another pathway known as the descending pathway from the cortex that comes down and closes the gate. Now, what happens with all these chronic pain patients is that the gate never closes. You give whatever drug, but please understand our work should be on the gate. So now, how to define chronic pain? Any persisting pain that lasts more than 3 months and negatively affecting an individual well-being, it can be a chronic pain. What is required is physical therapy, psychological therapy, acupuncture, TENS and yoga. How does acupuncture and TENS work? It works by the gate. It saturates the gate. It closes the gate. How does yoga function? It amplifies the inhibitory pathways from the cortex. So rather than giving a drug, our focus should be on these things. And the drugs, obviously, we know they're available there also. Gabapentin, pregabalin, a lot of things are there. Nortriptyline. There are combinations also that I see. I saw a combination with gabapentin 400 plus nortriptyline 10. So yeah, I think they require all these drugs. You can use them. So when to refer to a pain specialist? We don't have a pain specialist as such in INHS Ashwini. In maybe Kokilaben has, many of the corporate hospitals have. I think it's high time to include them in your pad care team, in your vascular surgery team. See, teams are always very important. Let's just face it. And a pain specialist is very important, especially when the pain is extended in duration. Patients are opioid tolerant. If they are taking, let's say, oral morphine more than 60 or tramadol more than 600 milligram in a day, they could be opioid tolerant. These patients actually require a pain specialist to manage them. And as as we know, in substance use disorder patients, with some other addictions, it's a difficult thing. You should refer to a brain specialist. So, thank you once again. I hope I made it in time. And I request you moderator to continue.
Hi, good morning still. It's not yet afternoon. So I probably am the last person standing between you and the lunch. So my topic today would be varicose veins. Why one type of solution does not fit all. I'm Dr. Aniruddha Bhuya. I'm a vascular endovascular surgeon. Now, whenever a patient comes to you, you always tell the patient, pair upar rakho, keep the legs elevated. But are we taking it too far? Are we not treating the problem at the core of it? Let me start with a small case. This patient comes with a right leg swelling for 3 years in duration. He has a skin discoloration, the itching which has progressed. The symptoms do indicate a chronic venous insufficiency, and the condition has worsened over a period of time. Now, this patient comes. How many of you would think this is a primary vascular varicose veins problem? Show of hands, please. Would think it's a primary varicose veins problem. Probably most of the guys he had gone to also thought the same. And this patient was posted for a endovenous laser ablation in one of the centers. This patient came for a second opinion, and as usual, I found the symptoms not matching. So we did an MR venogram, and the MR venogram showed a very highly thinned out right common iliac vein. Now, should you go ahead for an ablation for this patient? It's a definite no-no. Will the symptoms improve? I don't think so, because you'll be killing the only vein, that is a superficial vein, which is draining the right leg. And why was the venogram not performed in the first instance? Probably we need to see more cases like this to actually treat such patients. Another type of patients. The patient comes with a swelling of the left leg, lot of discoloration. A patient has been told, advised to undergo a laser. The stockings are not helping. Again, MRV shows something called as a May-Turner syndrome, a compression of the left common iliac vein by the right common iliac artery. There are multiple ways these patients may present, and in such patients we normally do an IVUS. This is another patient where the patient had a completely occluded left common iliac vein, confirmed by IVUS. A lumen gain calculation was also done, and post venoplasty and stenting, the vein completely opened up. And such a patient we can actually do with minimal to low contrast, where the entire procedure can be done with an IVUS. The vessel can be opened, and the only shoot what you require is the last shoot, which is the venogram. Patients can also come to you with varying type of diseases. It could be a large lymphovenous malformation, where you have to go and treat these patients slightly differently from a normal varicose veins or a deep venous thrombosis. You can get venous ulcers in various types, and the end result is these patients need to have a healed ulcer, and the ulcer needs to remain healed throughout life. Now, the main problem for venous incompetence is the reflux. So whenever we do such an evaluation, a Doppler is normally important, and the person doing the surgery should actually be doing the Doppler. So a person knowing what the pathology is can treat a pathology better. You can get multiple and varying types of venous incompetence in terms of staging. You can get something from a C1 to from a spider vein all the way to an ulcer. But what is important is that we try to treat only the C4, that is the pigmentation, C5, which is a healed ulcer, and C6, which is an active ulcer. Why good imaging matters? So whenever you send a patient for a venogram, an MRV or a CTV, it is important that you also know to read the venogram. In such a patient, although the patient may have varicose veins, but you see a highly heavily dilated IVC and the deep venous system. Do you think treating such a patient would actually give better outcomes? An echo was done for this patient, severe TR, a lot of pulmonary hypertension, and a heavily dilated IVC and deep venous system. So it's very important to understand the anatomy and the pathology of this problem. So how do we manage it? We first start with graduated compression stockings, preferably class 2. And if the patient has an ulcer or has a bleeding episode or discoloration, and the patient is not compliant for stockings, we do offer them surgery. This picture out of this entire presentation has been taken from a book, because that is how much we don't do open surgery nowadays. Radio frequency is done where you do segmental ablation of the great saphenous vein. This is one of the patients where the patient has a venous ulcer, and what is done is you puncture the great saphenous vein. You put a laser fiber all the way up from down. It is preferable to do it to prevent a saphenous nerve injury, but we use a 1940 fiber which can also be done for below knee. And you ablate the great saphenous vein from the saphenofemoral junction all the way down. There is also something called as foam sclerotherapy, where we use a SRE method, air as well as the sclerosant, and make foam and inject. This is the similar patient where we are injecting foam into the smaller veins where we cannot do a laser. You also have microsclerotherapy, in which we go into the small spider reticular veins and we inject sclerosant into those veins. This is primarily cosmetic in nature, does not have any functional outcome, and you see the complete whiteout of the veins post the sclerosant. This is the backflow of the blood into the catheter, and you inject foam and it just whites up. Again, cosmetic in nature. There is another modality called VenaSeal, where we ablate, glue the vein up. The VenaSeal is like a long catheter with a gun placed at the end, and you inject cyanoacrylate glue into the vein, and it goes drop by drop by drop by drop from the saphenofemoral junction all the way down. There is also something called as catheter-directed sclerotherapy, where we inject sclerosant into the vein, and it empties the vein. So as you inject the foam, the blood comes on the other side. So it's something called as vein emptying sclerotherapy. Most important thing to note is that you should know the difference between a post-thrombotic syndrome and a varicose veins. So many a times how it does look, a patient who has been stented outside for a DVT in the island vein ends up having a completely low flow system, and you see the blood per se just goes up to the stent and gets blocked. So it's very important again to know that these patients, stent is also not the answer for all DVTs. You should understand that there should be a good inflow, there should be good outflow, only then you can connect both of them. So when to operate such patients, normally you should know, the main plan is you have an occlusion, you find a good inflow, you find a good outflow, you connect both, and then you can stent and open up. I'll be quick here. I'll not be showing you these videos. IVUS is important. What if you do not know, meaning do not have a good vein to open with a balloon on a stent? You try the wire doesn't go through. There is still an option of a bypass. This is called a veno-venous bypass, where you remove the great saphenous vein from one side, put it on the other side, connect it, and the blood goes from the left into the right and goes up. This is called the Palmades procedure. Also, swelling in the leg could not always be venous. It could also be an AV malformation. It is very important to clinically auscultate or find a bruit if there is a swelling. And such patients then undergo something called as a glue embolization, where we selectively go into the blood vessel and embolize, and thereafter excise the mass. Also to note that all swellings are not venous. They could also be lymphedema. So similarly, treatment should be given to such patients in a different way, but you should, if a patient has a lymphedema and a venous incompetence, treating the venous incompetence may just reduce the swelling by about 10-20%. But the main problem is the debulking. The lymphedema needs to be treated in such patients. Is it just a varicose veins or it's a post-thrombotic? So any patient, a golden rule is edema, discoloration. You always screen for a post-thrombotic syndrome, especially if the patient has a history of a DVT. Thank you very much.
Thank you, Dr. Anirudh. I thank all the speakers who have taken their time to explain us about vascular disease. I hope there is some increased awareness between all of us so that we can achieve the amputation-free India goal eventually. And can I request all the speakers to please come for a picture here, and Dr. Rakesh Jha